Welcome to part 3 of renal GU disorders. This part is going to focus on the difference between acute glomerulonephritis versus nephrotic syndrome. One of the ways I want you to try and remember the difference between these two is looking at Pillsbury Doughboy versus Michelin Man. When you look at the degree of swelling in acute glomerulonephritis, it's much less than what we see with nephrotic syndrome. So that's why I put in these two guys to help you remember. Pause the video for a minute so you can jot down the variety of nursing diagnoses that are applicable when developing a care plan for a child with AGU, AGN versus nephrotic syndrome. Acute glomerulonephritis is caused by a strep infection, and so we call it a post-group A beta hemolytic strep infection. It causes inflammation within the glomerulus related to invasion of immune complexes. This, in turn, causes a decrease in the rate of glomerular filtration. These pictures give you a visual of the areas within the glomerulus that are affected by this illness. And this table, which you will also find in your textbook, give you the classic symptoms of fluid retention, periorbital edema, a decrease in the urine output, and the urine is a dark tea color because of capillary permeability, and it's actually blood. But when it's coming from the kidney and not the bladder, it has the tea color. There's also an elevation of the blood pressure. So as I just said, hematuria causes the tea-colored urine. The edema affects the face and the periorbital area, especially in the morning. There's a reduced urine output, and the hypertension that develops can actually lead to encephalopathy as well as seizure activity. You can anticipate the following diagnostic studies being ordered, and you would want to be looking for the results. For the urinalysis, we're going to see hematuria on the dipstick as well as mild proteinuria. And I emphasize mild because when we compare this to nephrotic syndrome has far more proteinuria. There will be an increase in the BUN and the creatinine levels, but it usually is not to the degree that it would cause renal failure. And one of the pathognomonic tests that tells us that this is glomerulonephritis is the presence of an ASO, and this is the anti-streptolysin antibody titer, and that tells us that we have had a recent strep infection because nephrotic syndrome is not caused by strep. There is also generalized inflammation, so the sedimentation rate, that's abbreviated as the ESR, is going to be elevated. These children are admitted to the hospital, at least for the first couple of days. However, they are sick for up to a month, and then there is a small subset of these children that will develop chronic glomerulonephritis, and they'll take that all the way into adulthood. We administer antihypertensive agents. So ACE inhibitors can be used if necessary. They can have diuretics such as furosemide. You want to implement seizure precautions because if the blood pressure gets to be so high that they develop seizures, you want to protect them. During the acute illness, we are going to restrict fluid. Their diet may also change in terms of the sodium because they'll have a low sodium diet due to the edema. We put these kids on bed rest because they're not very comfortable and they're fairly critical. As their urine clears, and we'll monitor that with the urine output as well as the degree of proteinuria, and as the blood pressure reduces to their more normal, then activity is going to increase. So the medications that you would anticipate are going to be antihypertensives, diuretics, antibiotics if there is still active strep infection, but many times this isn't the case, and then administer pain medications as needed. Remember, when we are administering diuretics, it is very important that the nurse knows when to expect the result of that diuretic therapy, and in turn, you monitor the urine output. Now we're going to move on to nephrotic syndrome. So this is quite different in that it isn't caused from a bacteria. It's more of an immunologic problem. There is an increase in the glomerular permeability to protein, so they dump a lot of protein. When you look at the urine dipstick, it will be 3+ or 4+. As a result, their serum albumins are going to be markedly decreased, much less than the 2.5 milligrams per deciliter that is normal. And if we were to send off an ASO titer for these children, it's going to come back negative. They have a decrease in the oncotic pressure, therefore vascular leakage that causes edema. The decrease in the vascular volume causes secretion of the antidiuretic hormone, and so this child ends up holding on to more water and more sodium, which results in more edema. They are in a hypercoagulable state related to a decrease intravascular volume. They also have an elevation of the RBCs and the platelets, but this is a false elevation, and it will correct once we have the volume corrected. They are immunosuppressed related to a loss of a lot of immunoglobulins through the urine. Here is another table that's from your book. And you can see the pathology of what goes on, why this child ends up with hypertension, swelling, hypovolemia, and the significant proteinuria. So what is this child going to look like? Well, they have a lot of edema. It starts in the face and it's very severe, and then it moves down the body. Because of the edema, they have weight gain. They have ascites, and the increase in the intra-abdominal pressure leads to respiratory and digestive difficulties. These children can develop pleural effusions, and when you have a pleural effusion and immunocompromise, this can lead to an empyema in the lungs. They have quite frothy urine, and their blood pressures can either be normal or low normal. Let me go back to this slide. This girl that's in the picture, she is at a camp up in Lake Arrowhead that is specific for children with nephrotic syndrome, because nephrotic syndrome is chronic and they will have remissions and exacerbations. So their life and quality of life is definitely altered. Here is a good picture of the severity of edema that occurs with nephrotic syndrome. And it is amazing, as soon as we implement treatment measures, that edema goes down. The diagnostic evaluation for nephrotic syndrome includes a urinalysis, where you're looking for the protein. There will be an increase in the specific gravity. As I stated earlier, they're going to have decrease in the serum proteins, albumin, and the sodium. The H&H and platelets are going to be elevated, and they have high cholesterol and triglycerides. And these levels are 400, 500, up to 700. Why do you think these parameters are elevated? What does nephrotic syndrome have to do with lipids? Well, when you think about lipids, they are lipoproteins. And so when this child is dumping so many of their proteins into the urine, the liver responds by making a lot more lipoproteins to maintain the oncotic pressure. These children are also admitted, and when they're trying to figure out what to do, they also will have the child get a renal biopsy. The management of nephrotic syndrome includes the ABCs. We're going to treat any of the respiratory and cardiovascular complications immediately, as well as hypovolemia. We have to be careful with the fluid support because we don't want to fluid overload them at the same time. We need to support the child and the family through the illness because, as I said, they have remissions and exacerbations. We administer steroids. Now, typical steroids are prednisone, and for children, the usual dose for most things requiring this anti-inflammatory is 1 milligram per kilogram per dose. However, for nephrotic syndrome, it's 2 milligrams per kilogram per dose. And then this dose is tapered based on the response and a decrease in the urine proteins. And eventually, as the urine proteins get to 0, then this child can be fully weaned off of the prednisone. They may need antibiotics as a prophylactic means or because they develop an active infection due to their immunosuppression. They may need medications for the gut because of the ascites impacting their ability to have peristalsis. Pain meds due to edema or whatever else is going on. For the patients who have a persistent relapse, they are going to go on a much higher level of medication, Cytoxan, which is a chemotherapeutic agent, and cyclosporin. And cyclosporin increases the chance of infection even more. We will restrict sodium, protein, and calories. We will restrict sodium during the illness, and we will have them have a little bit more protein in their diet and promote calories. This child is also going to be on bed rest and will increase the activity as the edema improves. Prevent infection related to the disease and because they're taking steroids and they have edema. Protect this child's skin. When we're turning them every 2 hours, make sure that you are turning them with the best body mechanics possible and that you're not shearing off their skin, because this is going to cause injury as well as increase the risk of infection. For pain, use a developmentally appropriate assessment tool, and then use pharmacologic and non-pharmacologic pain management. Assist the child with alteration in body image. This is going to be more pertinent to the school-aged and adolescent teenager. We also need to help them cope with illness. For the child who has this as remissions and exacerbation over and over, we eventually teach them to take care of their illness on their own. Refer to your textbook for more on the nursing and medical management of acute glomerulonephritis and nephrotic syndrome. This ends this section of renal and GU disorders.